Hello, my name is Caroline, and today I'll be exploring the molecular mechanisms behind the cystic fibrosis, also known as cystic fibrosis of pancreas, fibrocystic disease of pancreas, mucoviscidosis, if I'm pronouncing correctly, or simply CF, and this is how I'm going to refer to this condition, okay? So CF, it is a genetic disorder and autosomal recessive, so it is not sex-linked. Every biological sex can have equal chances to have this condition. Being a recessive, it is needed both copies to express this condition as well. So basically, it is caused by mutations in the cystic fibrosis transmembrane regulator, the CFTR gene, located in the chromosome 7. Okay, and this CFTR gene encodes to a protein that functions as a chloride channel that regulates the movement of chloride ions across the cell membranes. And this process is super important and essential for maintaining the proper fluid balance and mucus production in different organs, but especially the lungs, the most affected in most of the cases. So a super common mutation for CF is the F508 deletion, and it is responsible for 70% of the cases. And as we know that we have more than 2,000 variants for this gene, and this specific one is responsible for 70% of the cases, is quite interesting. And it is the result of a deletion of a single amino acid, the phenylalanine, from this CFTR gene. So this mutation caused the protein to misfold and be retained in the cell, and it prevents from reaching the cell membrane. So the protein just don't have the function because it doesn't reach the place that it needs to be. So when the CFTR protein is not functioning correctly, it leads to a buildup of a thick, sticky mucus. And this mucus can have several negative impacts like lung obstruction. So in the lungs, the mucus can clog the airways, leading to chronic infection, inflammation, and a difficulty breathing. Pancreatic dysfunction, so the pancreas, the mucus can block the ducts that carry digestive enzymes, leading to some kind of malabsorption of nutrient deficiencies. This word is difficult. In addition to all these direct effects, the thick mucus can also create a favorable environment for growth of bacteria. So even though that it's believed that carriers do not express any symptoms and they are 100% good, some new literature have been reporting more susceptibility to certain conditions, certain infections, especially for Pseudomonas aeruginosa in carriers and heterozygotes compared to people who are not carrier, just a dominant homozygote. So cystic fibrosis is a chronic and usually progressive disease. Symptoms can start at birth, and it will involve the lungs and gastrointestinal tract. And also a common presentation might include a thick secretion and chronic infections in the lung. So abnormal airway secretion, as I mentioned before. These individuals are typically diagnosed by newborn screening, but they may be diagnosed later in life. So in terms of diagnosis, it requires a typical clinical syndrome and can involve laboratory confirmed protein dysfunction, presence of the two disease-caused mutation. They also can use a sweat testing to confirm the protein dysfunction. So if the sweat is super concentrated, the newborn screening may presumably diagnose cystic fibrosis before symptoms, and it would be nice for a start of treatment. In terms of epidemiology, I read a lot that this condition is mostly common in Caucasians, but I think these affirmations can cause more harms than actually teach us as researchers, as genetic counselors. So I would say that even though that it's most common in what once they called Caucasians, I would say to not expect any diagnose or just disconsider diagnose just because of phenotype of someone, because the phenotype not always is 100% attached to the genotype. Most of the cases is not. Okay, we have the environment playing some impacts as well, and a phenotypically black person can also have cystic fibrosis and so on. So I don't want to make this affirmation here on my presentation. The oldest of the oldest therapies included bronchial drainage and a broad spectrum antibiotics for the increasingly resistant pathogens, pancreatic enzymes replacement with vitamins. The new line of treatment involves signaling correctly the CFTR proteins to their assigned place. So they actually gain their passport to the cell membrane, and the patient can have a better life, not the perfect one, but a better condition. For support groups and resources for patients, I found the Cystic Fibrosis Foundation, which is incredible, and it goes beyond from patients but also to researchers. I found a tab that explains and have listed all the scholarships and fellowships that have something related to cystic fibrosis. So if you study cystic fibrosis or you plan to do that, please check that out, and you're gonna see great opportunities for your research. Thank you, and see you next week for our last presentation. Bye.